All right, welcome. In this explainer, we are going to break down the core concepts of diet therapy, specifically the routine hospital diets you'll be seeing day in and day out. Look, for any of you going into clinical nutrition, mastering this stuff is absolutely essential. It's really the bedrock of effective patient care. Okay, so here's our game plan. We're going to start with the absolute basics, the foundations of diet therapy. Then we'll get into the nitty-gritty of how you actually plan these diets. After that, we'll look at how we adapt a normal diet for clinical use. And finally, we'll put it all together and walk through the routine diets you'll actually see in the hospital. So, first things first, let's get a really clear clinical definition of diet therapy. What are we actually talking about when we use this term in a hospital setting? So, what's really crucial to get here is that diet therapy isn't just, well, giving people food. It's a deliberate clinical intervention. Think about it. We are strategically using food as a biological agent. The goal? To help the body recover, to reduce the metabolic stress that comes with disease, and of course, to prevent any nutrient deficiencies. It's not just about feeding people, it's about treating them with nutrition. That's a huge shift in perspective. A good therapeutic diet is really built on these three core ideas. First, it has to be psychologically acceptable. If it looks and feels like normal food, the patient is way more likely to actually eat it. Second, it's got to be practical. We often simplify things to manage time and cost. And finally, and this is the big one, it has to ensure nutrient balance. We're using calculated values to make sure that even with restrictions, we're not causing new problems. It's a real blend of science, psychology, and practicality.
All right, so we know the what and the why. Now let's get into the how. How do we actually plan a therapeutic diet? This is where all that theory meets a real individual patient.
And as you can see, planning is so much more than just looking at the disease. It's a totally holistic process. We're taking clinical data, like the diagnosis, and blending it with deeply personal things like what the patient likes to eat, their culture, even their financial situation. This is the biopsychosocial model of care in action. We're treating the whole person, not just their chart. Okay, these four attributes, think of them as your non-negotiable checklist for every single diet plan you create. You have to ask yourself, is it adequate? Does it meet all their nutrient needs? Is it accurate for their specific condition? Is it economical and practical for them? And maybe most importantly, is it palatable? Is it something they'll actually eat? If the food just sits on the tray, it's not doing anyone any good, right? Top-tier standards, like those from ESPN, really hammer this home. Hitting all four is fundamental. So, how do we get from a regular diet to a therapeutic one? Well, we don't have to start from scratch every time. Instead, we've got a toolkit of specific modification techniques we can use. The answer really comes down to two basic approaches. We can either change the type of food we're offering, or we can change the amount of certain nutrients within that food. This slide lays it out perfectly. These are the two main levers we can pull. On the one hand, you've got qualitative changes. That's when we alter the very nature of the food, like switching to a liquid diet. On the other hand, you've got quantitative changes. This is where the food might seem similar, but we're precisely adjusting the levels of something specific, like creating a low-sodium diet for a patient with hypertension. Okay, let's make this real. Let's see how all these principles actually apply to the routine diets you're going to see every single day in the hospital. We'll start at the bottom and work our way up. This is ground zero for a lot of patients, especially before or right after surgery. The goal here is super simple. Give them fluids and electrolytes while letting the gut rest. We want the absolute minimum strain on the digestive system. And if you just look at the numbers here, its purpose becomes crystal clear. This diet is not about nutrition, not at all. With only 400 to 500 kilocalories and basically no protein, its only job is hydration and electrolyte replacement. And because it's so inadequate, that leads us to a really critical clinical warning. And this brings us to a super critical point. This number, 24 to 48 hours, is the absolute maximum. A clear liquid diet is nutritionally inadequate by design. You cannot leave a patient on this for more than a day or two without some kind of additional nutritional support. If you go longer, you risk what's called iatrogenic malnutrition. And that means you, the clinician, have actually caused the malnutrition through the treatment. It's a huge deal. Okay, the next step up the ladder is the full fluid diet. Now we can start bringing in things like milk, creamy soups, and yogurt. It's a really important bridge, giving us more calories and protein once a patient is ready for a little more than just clear liquids.
Now, the soft diet, this is a major milestone for a patient. We're talking about a nutritionally complete diet now. It's still designed to be really gentle on the digestive system, soft textures, low fiber, but it's providing the serious energy and protein they need for healing. Now, here's a distinction that is clinically vital. You have to know the difference between a standard soft diet, which is all about GIEs, and a mechanical soft diet. Mechanical soft is for a totally different reason. It's for patients who have trouble chewing or swallowing. The food isn't just soft, it's physically changed, chopped, minced, or pureed to make it safe to eat and prevent choking or aspiration. And here we've got the final stages and a few special cases. The normal diet in a hospital is actually a bit different. It's slightly modified for bed rest, a little less energy since they're not moving much, and a little more protein to help prevent muscle loss. Then you have these really specific diets, like the cold semi-liquid diet after a tonsillectomy to soothe the throat, or a blenderized diet that lets someone with a wired jaw get complete nutrition through a straw. So this slide sums it all up really nicely. This is the typical step-by-step progression we use to safely get food back into a patient's system. We call it advancing the diet, and it's something we monitor very, very carefully. We have to make sure the patient can tolerate each stage before we move to the next. It's all about minimizing complications and supporting a steady recovery. At the end of the day, mastering these routine diets isn't just some academic exercise. It's a fundamental clinical skill. Your ability to apply these principles correctly has a direct impact on a patient's safety, how fast they recover, and their overall quality of life while they're in your care. So this leaves us with a pretty cool thought to chew on. Everything we've talked about today, these are the foundational principles right now. But the future, man, it's incredibly exciting. I mean, think about it. With everything we're learning about personalized medicine and the gut microbiome, how is that going to totally reshape these routine hospital diets? That's not just a rhetorical question. It's a question that you, in your careers, are probably going to help answer. Pretty amazing, right?